Our next presentation, we're moving now to the world of implementation science. And our next presentation is going to be on antimicrobial stewardship, presented by Doctors Tamar Barlam and Mari-Lynn Drainoni, if I can invite them up to speak. So Mari-Lynn is as a research professor in the section of infectious diseases, co-appointed in the School of Public Health. And she is the co-director of our Center for Implementation Science and Improvement Science. It's funded by the Evans Center as well as the CTSI. CIS, as we call, or CIS as we call it, is really has been a tremendous boon to our scientists. It hosts a research fellowship for 1 year and also provides a resource for any scientists in our community who are interested in applying implementation and developing implementation methodologies to their question. Dr. Barlam is the chief of the section of infectious diseases in the Department of Medicine, professor of medicine, and also the director of hospital epidemiology here at BMC. And together they're going to speak to us about utilizing telehealth for improving antimicrobial stewardship. Thank you very much.
Yeah, so we're going to discuss a project that we started about a year ago. It's an R01. It's funded by AHRQ. And I'm going to go over the background a little bit, and then Mari-Lynn is going to talk about our aims for the project and our methods. Okay, so antibiotic resistance is is a huge public health threat. It causes millions of deaths worldwide every year, and it markedly increases healthcare costs. And I'm mostly focused in my day-to-day on inpatient antibiotic stewardship, but a lot of the inappropriate uses in the outpatient setting. So in the United States, outpatient visits result in an antibiotic prescription about 13% of the time. And of those prescriptions, about a third are inappropriate. But if you look at the proportion that are due to prescribing for respiratory tract infections, half of the antibiotics are for respiratory tract infections, and an even higher percentage, 50%, are inappropriate or unnecessary. So there have been decades worth of evidence-based guidelines that advise against antibiotics for the majority of acute respiratory tract infections, because the majority are caused by viruses and not by bacteria. There have been randomized controlled trials. There have been really level A data that says that this antibiotic use is not necessary. But despite this, the inappropriate use continues and the practice remains poor. And it's clear both in the literature and in our own research that this is not because of knowledge gaps. The providers actually know the guidelines. They know that most of these cases, they should not be given an antibiotic. But interventions to try to improve this, particularly in the adult population, have largely had minimal impact. And although they may work in the short term, they have not been shown to be sustainable over time. And so, again, in the literature, but with our own prior research, when you look into why providers say that they prescribe, they are quite risk averse and they don't want to miss something. And there is this belief that action, i.e. a prescription, is better than inaction. They're worried about the relationship with the patient. If the patient expects an antibiotic, that they'll be disappointed and they'll be dissatisfied with the visit. And there's also time pressure in terms of outpatient setting. You have to see a certain number of patients within a certain time frame. And it does take a lot longer to explain why a patient does not need an antibiotic than to just write a prescription and give them an antibiotic. On the patient side, they have these experiences where they feel antibiotics have helped in the past, so they feel they'll help again. And also the idea that they don't feel well, they come to a visit, they sit in the waiting room, they wait for the doctor, they see the doctor, and then the doctor says, take tea with honey. They don't like that. So they want an antibiotic. They want something tangible. There have been evidence that these prescribing practices are different based on race and ethnicity and gender. And it's different both in prescribing and also in patient expectations. So obviously COVID was a very bad thing. But The interesting thing of COVID is it did transform the idea that telemedicine could be acceptable. And that had really not been true in really in the American health system, except in pockets where there was some telemedicine use. And so we hypothesized that telemedicine could perhaps improve the efficiency of the visits and also reduce the burden on patients who have a respiratory tract infection, and they might be more willing to accept not getting an antibiotic than if they came to the office. However, the few studies, and there really aren't that many, but the few studies before COVID that looked at telemedicine interventions for respiratory tract infections actually have had mixed results. Some studies have shown that antibiotic prescribing actually went up because the doctors weren't able to examine the patient. They weren't able to really look and see, listen to their lungs, look at their throat, et cetera. So again, because they were worried they'd miss something, they would give the prescription. And in terms of patient satisfaction, even with telehealth, the satisfaction was linked with antibiotic prescription. So I'm going to let Mari-Lynn take over here.
I'm going to talk a little bit about our methods. And again, Tamar said, we really thought a lot about translational science in this and translational goals and really bridging the gap between provider behavior and patient knowledge and expectations and all these pieces. And so we decided in our study, we would really focus on addressing both patient behavior and knowledge, but also provider behavior, rather than assume patients don't know anything or don't have education. And also that providers don't have education, because I think all the studies have been really clear that they know this. We also wanted to use the science to be sure that providers would feel safe. We felt like that was a really important translational goal. And we tried, probably not as successfully as Tracy and her CE core, but to use principles of community engagement in our work. And we're using learner verification with iterative provider and patient involvement, which is what I'm going to focus on today, actually, in materials review and creation. And then we use the transcreation process to ensure the cultural relevance for people who are racially and ethnically diverse or with limited English proficiency. It's actually been fun and interesting work I hadn't done before. And then also it's really important translationally for us to create an intervention that it's feasible and acceptable for all the parties. And that we won't really get into AIM-3 yet today because we're not there, but it's been interesting even to see across our health systems some of the differences about what will be feasible, because we want to look at the health system as we're going to create a telemedicine process, patients and providers. So, and we felt like, implementation science was like a perfect fit with translational research in many ways. And for me as an implementation scientist, the best thing about being one is you don't work alone. You work in partnership with clinicians, patients, other folks. So it's great. So, because the idea of implementation science, again, is how to retranslate evidence-based research or research findings into practice and policy so we can improve health outcomes. And to us, it's a real key component of translational research, which really aims to bridge the gap between science and real world application. They don't actually get talked about a lot together, but I think they're really important partners together. So our study really links these two things and includes a really high, we think a high level of patient and provider engagement. So what we're doing, our study is a hybrid effectiveness implementation study. That's an implementation science term, hybrid studies. We're looking at both effectiveness of something, of our intervention, and also how we implement it, the implementation outcomes. To look at whether moving toward telehealth for low risk, so working on that first, low risk acute respiratory tract infection encounters would be effective, would be feasible, and be a sustainable approach to improving management and outcomes in 3 diverse systems at 6 sites. So what we're doing, and I'm going to focus on AIM-2, but just to give you some background on what we're doing. So in our first AIM, what we need to do is figure out what is low risk, right? What predicts a bad or a good outcome. So with the heavy quantitative heavy hitters on our team, we're developing and validating a prediction tool to identify patients who are appropriate for ARTI management via telehealth. So we're working in 3 systems, our system, BI Deaconess, and Leahy. So 3 big systems that are quite different from each other, which was important to us. And we have data from those 3 systems over 5 years. And we're developing our risk score. We're actually developing it on Leahy, which was actually the biggest site. And also we felt like the most middle site in terms of characteristics of patients, and then we're validating it on BMC and BI data. And we're also working with each of these systems to understand the triage process and incorporating the risk tool into that process. And as we thought it was going to be really easy and simple, and the triage process is really complex, especially when 2 of the sites are in the middle of moving their EMRs. So it's been an interesting challenge. And so our goal here is really to address what we heard from providers and hear from providers regarding risk if they don't prescribe. To really, what is low risk? What does that mean? And we could spend hours telling you about the risk score, but we won't today. The second aim, which is where we'll focus on, is really to work with clinicians and patients to co-produce guideline concordant materials, and with providers and staff to also identify the implementation strategies for doing it. So we're going to focus on what we've been doing today around the guideline concordant material production, primarily with patients. So what we did is we did qualitative interviews with providers to explore their views on some materials that we actually created. We have a big set of clinicians on our team, as well as myself and a statistician across all the sites. So we created materials and then we reviewed them, had the providers reviewed them. We also created patient materials, and we started in English. And we shared some materials with them, and we're doing interviews and focus groups. We wanted to do all focus groups, and we just had to do what was doable with patients. So we've done both. We're doing this in 5 languages. We're doing it in English. We started with that, and those are almost done. And we're in the process now. We've started in Spanish and Haitian Creole, and we're also recruiting in Russian and Portuguese. Leahy actually has a site with a big Portuguese population, and BI has a large Russian population. One of our BI sites, Chelsea, also has a large Spanish-speaking population. And of course, we have a large Spanish and Haitian Creole population. We had to limit it to 5. I think we probably could have done more, but there are just some financial limits. So we wanted to get kind of the top languages. And the goal of this is really to create together provider and patient-friendly and relevant materials to really supplement the visit, which people have said to us was important. And then the last thing we're doing, and I'll get back to that process, is we're going to pilot test implementation across 6 clinical practices, the main sort of flag mothership hospital, ambulatory care site, and 1 health center connected to each site. Really a diverse demographic and socioeconomic patient population. And then we're looking at some implementation outcomes like feasibility, penetration, equity, sustainability, and satisfaction. And then our effectiveness outcomes are prescribing, of course, appropriate prescribing, kind of more of a process outcome, and then clinical outcomes at 14 days. Do people get hospitalized, or are there other negative clinical outcomes? We want to evaluate the material. So this is sort of the first step, and then a much larger trial. So just wanted to share a little bit with you, like the material. So what we did is we started really with advertising. And we did this in 6 languages, but we basically have reached out to patients saying, have you been treated? And almost all of us have ever been treated for this. We were trying to really do it within a more recent time frame and telling them, we're doing a study to do this, contact us, we'll have a focus group. So we did it in English. I just wanted to share quickly the materials in the other languages. Here's Spanish, they're exactly the same, and Creole, Haitian Creole, Portuguese, and Russian. I wouldn't know that, but I know that's in Russian. So that's what we sent out. We also, to recruit patients, we started with that at all the sites. I think if anyone's in GIM on 5th or 6th floor, they probably saw these materials when they got off the elevator, and did that, and doing that at all the sites to start with the creation. And then we also, there were some challenges. So we did a letter basically saying, got IRB approval, you've had a visit, can we contact you? And that letter was also sent out in multiple languages. Of course, that's challenging, but we have to go by the languages in the EMR. So we did that to get people. So then what did we share with them? So as I said, we did we created some materials in collaboration with our colleagues for patients. And they really talked about, they're not that big here, but they started with antibiotics may not work. And we had a table, and, be aware they can cause harm, and there's other things to do. We did in focus groups. I think we did maybe about 12 or 16 people. And then we got some feedback on it. We started in English. It was only thing was feasible. I don't speak any other languages fluently. So we started these in English and started with the feedback. So this was our first sort of stab at it. Our second stab at it is somewhat the same. We really wanted patient feedback, but it's also somewhat different. And it looks like this. So what did patients really say to us after the first stab? They said, don't start with antibiotics might cause harm, but start by telling us that things will go away, that they'll get better on their own. That was really interesting feedback and something we wouldn't have thought of without patients. They also said a lot more graphics. You'll see there's a lot more graphics and pictures here. We can read it. They said, don't worry, we can read it. The language is simple. You did all that, but more pictures, make it more appealing. So really think about that. More boxes. We have a box in the middle that now under antibiotics can cause harm. And they said, use the word beware, which was really, we thought it might be scary, but no, use that word, make it clear, talk about that. And then make sure you have something about what you can do, not just say it'll go away, it'll get better. Gargle, use lozenges, do this, but give some pictures. So that's what we did. Now we're in the middle of finishing up the English interviews and focus groups, and also we started them in Creole, Haitian Creole, and Spanish, and we're in the process of starting the English and the Russian and the Portuguese, and then we'll move forward. So we'll keep creating those. We've also run them by providers to get their input. We're also talking about patients of like, when would you like to do this? And when would you not like to get this information? And what they're kind of sharing with us is like, maybe something general before the visit via the EMR if we use it, or some other way, maybe something more specific after. So there are things we hadn't thought about that we're working on. And this is just what the materials look like in the other languages. They're exactly the same, except the language is different in Spanish, in Haitian Creole, and Portuguese, and in Russian. So that's really where we are. We've learned a lot. We're doing a lot. This is it's a big project. I think it's a lot more than we expected when we took on doing this kind of community engaged work. But we're getting there. In 2 more years, we should know a lot.
Hopefully.
I hope.
So it is, it's a work in progress. As Mari-Lynn said, we're now really starting to focus on the patients who are do not have English as a primary language. We've had a lot of provider and patient feedback, and I think overall it's been consistent. They've had input, but it's been positive. And I think it really reinforced how important it is to get those voices in, because there were a lot of ideas that we didn't come up with on our own, and there were a lot of tweaks that I don't know that we thought were important, but were actually quite important. The providers, we had developed provider materials, and there was really not that much interest in those, but they thought that we could make the provider materials, which were like diagnosis specific, and actually create them in at a level that would be more appropriate for patients. So maybe have the general before the visit, and then after, if they were diagnosed with bronchitis, use, a sheet. You have bronchitis, these are the medications, that could help you feel better. As Mari-Lynn said, the risk score, we're nearing completion, so we're excited about that to see, and then a lot of how we could implement that so that it's convenient for the triage process. And that's really our next steps. So that's our project, and we're happy to take any questions.
Any questions? Dr. Shanahan.
Chris Shanahan, General Internal Medicine, and one of those doctors that does this. I didn't hear in the intervention, I didn't hear what you did to the doctors. I heard that you asked them for input about what the information was, but the behavior is that they are prescribing when they shouldn't.
Right. Okay, so we didn't do anything yet.
Okay.
What we are doing, the main intervention with the clinicians is really, again, this isn't a clinician behavior intervention. We were really not thinking about, we're thinking about behavior change through systems change, if that makes sense. So by doing the risk score, I'm giving them that confidence. by intervening with them, by talking to them about that, the education. So it's much more in some ways of a systems level intervention to improve provider behavior. We were going to give them materials. They've clearly told us, might be good for other people, but not for me, because I'm great at this, which, you know, is probably not true, because none of us are great at everything.
Yeah.
So I'd say we won't be intervening at that same kind of traditional intensive level, but we're doing more of a systems intervention and the risk score.
And I just want to add that there have been probably decades of interventions that have been trying to change provider practice, and they've actually been quite unsuccessful.
Yeah.
They've shown either minimal improvements, but not sustainable. And so we were just trying to come up with a different paradigm and try to listen to what was said, which is the patients wanted, or often they're blaming the patients for things that aren't really true, but time pressure, so we thought that if we reduce their worry about risk with the risk score, because that was definitely important to some of the people we interviewed. And if we also had these materials that were almost prepping the patients that, you're not going to, antibiotics are not necessarily what you need for what's bothering you, plus removing some of the annoyance and trouble of coming for a doctor's visit.
So I do the exact same thing that you do. I actually don't give antibiotics very rarely. But it takes me time. I have to actually invest time into making sure the patient understands that I'm not blowing them off, and that it actually would have been a lot easier for me to just give them the antibiotics and send them on their way. But I've actually invested the time in them. So I have to make a calculation. I've made that calculation already, but I think for them, they see it as I've invested this time in them. Why would I do this otherwise? So I think there's some possibility to do something with the docs, but it would require changing people's perspective about what the value of their talking is.
Well, we're hoping that in a sense, we're doing some pre-work with the patients that you're taking the time to do in your visit with the materials.
Right.
So we're setting the stage, or we're attempting to set the stage, so it's not going to be a conversation that they're not expecting, if you will. So it's trying to make it more efficient, plus again, easier for the patient. So maybe it makes the conversations easier for the provider.
I think it's great that you're actually dealing with something that somebody is really having to deal with. This is a real issue.
Yeah,
Thank you.
Yeah, Chris, I think the other thing just really quickly is when we talk to the patients now in the early work, talking about resistance has made a difference for them. Knowing, as Tamar always says, it'll get better. What is it, 10 days or 14 days?
That's right. Bronchitis will get better either in 7 days or in a week.
With an antibiotic.
Right, with an
antibiotic.
antibiotic.
So, and hearing that and knowing that, I think that's made a difference. So I think the education feels important. Sorry, Tracy.
That's fine. Great presentation. Exciting to see the progress you've made. My question for you is relates to some of the synergies I see with the patient navigation work that we've done, and your final point here around next steps and incorporating this into clinic flow. And so while I totally appreciate, it's not really changing the provider behavior, it's really intervening at all these different levels. So I wonder if you could just share a little bit more about sort of the clinic sort of partners who you're sort of thinking about bringing in. It's like the call comes into the call center and setting expectations there to, what the nurse says or the MA says to the patient when they're rooming the patient, and sort of, I wonder what your approach is going to be there.
So I think our goal is to make it easier to do the right thing than, to do maybe not the right thing, right? So that has been something that we've understood. So we've had numerous meetings at the 3 sites with the different nurse triage, with the actual leader of nurse triage, as well as the nurses at the front lines. We've met with providers. We have a provider partner in the medical clinic at each site, where at our site, we're working with Epic as well, because BI and Leahy simultaneously are switching over to Epic right now. So we're not really sure how that's going to work out, but we'll learn it here at Boston Medical Center. But we definitely, it has to be people on the ground who, again, the process has to be seamless or at least easy, and it can't add time, clicks,
Mhm.
you know, any of those activities that would make it hard, but
Yeah, I think, yeah, it's been interesting here, one of our big partners is the head of practice management, Eric. He's been an important partner, but people at really
great.
all levels. And I think the other thing that, as frustrating as it's been, the BI Leahy experience, no one ever expects things to go so much better and easier at BMC than at BI Leahy, but they're going to. And I think they did. They're in the middle of changing EMR, and they're even doing things different, even though they're one system. But I think for me, it's an interesting opportunity to think about how can we do this in a maybe low resource system that doesn't have this, where we only can have 5 factors maybe in the risk score. So what's sensitive enough and specific enough? That's with our stats folks. And what can you pull? Like asking the patient if they think they have a temperature, but versus going into the EMR. So I feel like we're going to end up doing what we call our open pilot differently, because each of the 3 sites is in really different places, and BMC is going to be sort of the most advanced with its EMR, and we have an amazing Epic team here. But I think it'll be a good learning about how can this be done manually. And also they have very different call system structures, a
Mhm.
triage structure, whether they use macro templates. And it's been really interesting to learn that, but it's been critical, Tracy, to the navigation piece of this is, I don't know, to me, like number 1 or number 2.
It's great that you've engaged the operations people.
Oh,
From
yeah.
we don't have time to talk about sustainability piece, but I think sort of getting at the institutional
It's the only way.
policy sort of level to sort of sustain over time. So great
It's the
work.
only way, right? Okay, thank you.